unfortunately, despite all new improvements in therapy, the majority of patients with non-small cell lung cancer present with metastatic disease. And quite a significant percentage of these patients have brain metastasis at baseline or will develop brain metastasis during the course of their disease. And I think also important to note is that in clinical guidelines, more and more often baseline brain imaging is advised to rule out asymptomatic brain metastasis. So the last years, the percentage of patients with diagnosed asymptomatic brain metastasis is increasing. Then you need to consider what you need to do with these asymptomatic brain metastases. If you look at clinical guidelines, so the ESMO and ESCO guidelines, then the ESMO states that in patients without an oncogenic driver, the treatment should be tailored according to the PD-L1 status. So high PD-L1 Pembrolizumab monotherapy, also for patients with brain metastasis, and chemoimmunotherapy for patients without brain metastasis. If you look at the ESCO guideline, they state that evidence is limited, but that chemoimmunotherapy is an option for patients with brain metastasis. And indeed, the ESCO guideline is right. In most clinical trials, patients with untreated brain metastasis were excluded. If you look at subgroup analysis of these clinical trials, so either monotherapy, immunotherapy, or chemoimmunotherapy, then patients with treated brain metastasis seem to derive the same or even more benefit from the combination chemoimmunotherapy or immunotherapy monotherapy compared with chemotherapy. But I think you really would like to want to know the benefit of immunotherapy in patients with untreated brain metastasis. There's been only one single-arm phase 2 trial so far, evaluating pembrolizumab in PD-L1 positive patients with asymptomatic untreated brain metastasis and a good clinical condition. And this trial showed that in general, the intracranial and extracranial response rates mirror each other, but that quite a portion of patients can have a dissociated response. So that patients with a brain response have extracranial progression or the other way around. So I think a message of this trial is that you can treat a patient with untreated brain metastasis, and I would say high PD-L1 with immunotherapy monotherapy, but you should really monitor this patient to see whether the brain metastases do respond, and you want to avoid neurological symptoms due to progressing brain metastasis. Last year, also, a trial with untreated brain metastasis and chemoimmunotherapy was reported, the Atezo-Brain. Of note, in this trial, up to 40% of patients used baseline steroids, which is usually an exclusion criterion in other trials. And in general, again, the intracranial and extracranial response rates were similar. And with the addition of chemotherapy, there were only 10% of dissociated responses. Also interesting, the 18-month PFS was above 30%, and I think that's quite encouraging in this patient population. So for me, I think screening for brain metastasis is necessary because otherwise you have the risk that patients present later in the disease course with symptomatic brain metastasis. Immunotherapy monotherapy for me would be an option for patients with high PD-L1, asymptomatic brain metastasis, and also not a high disease load outside of the brain, because then also you would like to have a response soon. And for the other patients, chemoimmunotherapy is an option. Brain imaging follow-up is necessary in these patients because not all patients do respond and dissociated responses occur. And what has been addressed by another talk by Dr. Levy yesterday was that we really need to investigate the sequence of treatment. Do we still need to start upfront radiotherapy, or do we apply radiotherapy or surgery upon disease progression if the patient doesn't respond to immunotherapy? And that's, I think, something for future clinical trials.